Oh, okay. Good afternoon.
And the answer was yes. And
Good afternoon.
That's right. Not louder.
So, good afternoon once again, everyone, here and online. To this beautiful Friday afternoon, I would like to welcome you to this session, this seed session. Our second session is here out of 26 planned. And I'd like us to get things started, get things moving early on. So, to begin this session, I want to request that we have a moment for introduction. So I'm going to ask all the panelists today to introduce themselves one by one. We'll start with the extreme end. Yes, please.
Good afternoon, everyone. Happy to be here again. And this is Mulago here. And my name is Dr. Andrew. Okay, please, thank you.
Thank you very much. Good afternoon, everybody. My name is Mwesigye Julius, nurse from Mulago.
Good afternoon, everybody. My name is Dr. Kabweru Wilberforce. I'm a senior consultant, and I head the Department of Thoracic and Vestibular in the Mulago National Referral Hospital. I'm happy to be here again.
So, good afternoon, everyone. My name is Mugyenyi Jonathan. I'm an emergency medicine resident. I'm going to be the moderator of our session today. And finally, I would like to introduce our case presenter today.
Good afternoon, everybody. I'm Baryamujura Sumaya, a pre-intern to the National Plan.
All right, so that's it for the introductions for today. Like to thank you all for attending and taking up your time to be with us today. You know, these eco sessions are geared towards management of life-threatening emergent conditions, for which pneumothorax and massive PE are one of them. So as we start this session, I would like to request that we take off around 5 minutes to do a pre-test and also take time to fill in our expectations from this session. So can we take off 5 minutes each to fill in the pre-test as will be available on the Zoom meeting, on the Zoom link. So I'm going to give everyone 5 minutes to just fill in these questions, and then we can continue. You have a hand up. Is there anyone with a concern? So we have a question from Okiror James Peter. You have a hand up. Please unmute and let us know your concerns while we fill in the pre-test, while the rest of our participants fill in the pre-test section. Within a minute, we're going to conclude the section on the pretest and move on to the next section.
We can't hear anything.
So I hope everyone has had enough time fill in the questions on our pretest for the session. While we're doing this, does anyone have any specific expectations from this session? Please feel free to put up your hand and let us know so that we can hear out your concerns and any expectations you might have from our session today.
Hello? Hello?
Yes, David, you are audible.
Thank you. I think I only saw one question out of 5.
Please scroll. Have you tried scrolling? Yes, please. We have another hand up. Christopher Wako. Please unmute and let us know your concern.
Thank you so much for this very wonderful session. I'd put my expectation when I was registering, but I can say it again now here. My question was, or my expectation was, in case I am in a remote setting where we don't have some of the facilities that I can read on the table, I don't have a chest tube, I don't have a drainage bottle, how can I help a patient with the attention pneumothorax? Is there some things that we can do to improvise for the items that have been displayed here? Thank you.
Thank you very much for that question, Mr. Wako. We have noted it, and one of the sections of this discussion today will talk about the pre-hospital care of patients with these conditions. And I hope our session's team and team of experts will be able to answer that question for you. We welcome any other questions and expectations from this session as we continue, so that we can move on to the next section. I have 3 hands up. Mr. Wako has given us his concern. Could we hear from Ambrose? Please unmute and let us know. What are your expectations and any concerns you might have as we begin the session?
Yeah, good afternoon, everyone. So I first of all thank all of you and thank you the management for putting this in place. So one of my expectations is that to learn how we can manage hypotension related to pneumothorax, because most of the cases concerning pneumothorax, you find that hypotension is a key. So basically, how can we put that aside? How can we manage it? Is it any position that is recommended? Because maybe the collapsing lung might be compressing on the inferior vena cavas and so on. So what's the best management? Thank you.
Thank you very much for your question, Ambrose. We have noted it down, and we hope as we continue with this session, our experts' opinion may elucidate more about the hypertension and its management. Can we have one more final concern, question, or expectations from Brian, and then we'll move on to the next section.
Yes, thank you so much. Mine is just brief. I just wanted to find out, in case a patient presents with tension pneumothorax, but as well they are having some blunt abdominal trauma. For instance, they're having a ruptured spleen and then with some gut perforations. How best would you go about to manage such a kind of patient? Thank you.
Thank you very much for your question. We have noted it, and as we go on with our session today, hopefully we shall meet you somewhere and get you some answers. So moving on, I would like us to start our case presentation so that we may get along to the content of our session. So I would like to welcome Dr. Sumaya Baryamujura for our case presentation. You may take up to 15 minutes. You're welcome, Sumaya.
Thank you. Good afternoon once again. I'm Sumaya, presenting a case on massive pleural effusion. ED, a 34-year-old male with no known chronic illness, a readmission, previously managed for pneumonia with a paralimonic effusion about 3 weeks ago, presented with a 1 week history of difficulty in breathing, left-sided pain, sharp in nature and worse on coughing, a productive cough associated with drenching night sweat, on and off high-grade fevers, and significant weight loss. On examination, we examined a young male seated in bed who was in obvious respiratory distress, restless, and sweating profusely. The air was patent and therefore maintained. Breathing, he was tachypneic with a respiratory rate of 48 breaths per minute. There were no distended neck veins. FPO2 was 85% in room air, asymmetrical chest movements with reduced chest expansion on the left side of the chest. Circulation, he had warm peripherals, tachycardic with a heart rate of 138 beats per minute. Blood pressure was 110/82. No pallor, capillary refill was less than 3 seconds. He was dehydrated with dry mucous membranes. A large bowel cannula was inserted. He was started on IV fluids, 500 ml of normal saline in hourly for 10 minutes. He was alert with a GCS of 15 out of 15. Pupils were equal in size and reactive to light. The neck was soft. Carnix was negative. RBS was 8.3 millimoles per liter. The patient was anxious and restless. He was given per oral morphine, 10 milligrams. On exposure, the abdomen was mildly distended, symmetrical. It was moving with respiration. He had a tender epigastrium. He had no organomegaly. There was shifting downwards. We ordered for an abdominal ultrasound scan. First medical history, he was seronegative with no history of any chronic illness, no history of drug or food allergies. He had no history of surgery, no history of blood transfusion. He had smoked for over 5 years and took alcohol occasionally. Our differentials were pulmonary tuberculosis. It could be a malignant effusion or pneumonia. Follow-up, a CBC was done. It showed a leukocytosis of 58.78 with a significant neutrophilia of 42.82. HB was 7.8 grams per deciliter with an NCB of 66.5. He had thrombocytosis of 1,288. The gene expert done was negative. A chest X-ray showed a left-sided pleural effusion. An abdominal ultrasound scan showed enlarged para-aortic lymph nodes and ascites. He was started on IV ceftriaxone, azithromycin tablets. We continued per oral morphine for 24 hours, IV paracetamol for 24 hours. We ordered for pleural fluid analysis, RFT and LFTs. The patient was to be reviewed by a pulmonologist. So that's the X-ray we did, showing the left-sided pleural effusion. Thank you for listening.
Thank you very much, Sumaya, for your case presentation. You have been concise and to the point, and you have used up around 8 minutes. So since we have a little more time, I would like us to address some of the questions. Thomas, please, could we look at some of the questions we have in our chat for the case presentation we have had, and we could address one or two of those before we move on. So any questions we have for our presenter, please put them in the chat or raise your hand, and we'll see how many of them we can answer before time catches up with us. Please feel free to put up your hands also and ask your question out loud. So Dr. Mary Ellen is also on the meeting, and she is moderating our question and answer section in the chat. Would any significant questions or anything of note she might answer within the chat section, or she'll bring up to the rest of us. I see we have a hand up from Mr. Moses Wambazu. So I would like to welcome your question. Please unmute and let us know.
Okay, hi, thank you so much, the ECHO team, for bring these sessions, and also thanks for the presenter who presented the cases. Maybe I might have missed it, but my question is about like what's the outcome of the patient intervention, because like we just got to know the patient was given that and that is it. So what happened? Did the patient improve? And now that we are dealing this in the light of tension pneumothorax, I believe probably this like later was confirmed to be a tension pneumothorax. So in line with that, what exactly was done? And maybe just to understand what happened to the patient. Did the patient improve, was discharged, was followed up, or things just ended like that and the patient like, kaput? Thank you. I hope I was clear. Thank you.
Thank you so much for the question. The presentation was majorly about the emergency treatment given, and the patient was later transferred to the pulmonology ward where he is being managed further and still being investigated for the cause.
Okay, thank you very much. If there are any other questions, we have two participants with raised hands. I would like to welcome Mr. Roger Zisiko. Please unmute and let us know your question.
Okay, thank you, presenter. I know it is a brief one, but it is very important to know what was your working diagnosis. We know pleural effusion is in most cases secondary to something, so I really want to know your working diagnosis. We might not have the definitive, but I want to know your working diagnosis that forced you to start the antibiotics and the follow-up. Thank you.
So I mentioned about the three differentials, but our most likely differential was a malignant effusion because this patient had these symptoms and yeah, the gene expert was negative and he had previously been managed for pneumonia. So we were also suspecting maybe he could be having sepsis.
Thank you for that, Sumaya. We still have. So to also add on to Sumaya's response, we're going to discuss a bit on causes of effusions a bit later. Those were the few they managed to trickle out for our patient. But in the interest of time, I'd like to invite David Niwamanya with his question, so that with a final question on the case presentation section, so that we can move on to the next section of our session.
Thank you so much for the presentation. My concern is from the presenter. She says the patient was previously managed for pneumonia, but I would like to know if the patient indeed got the right treatment and if they healed, and they went home when they were treated, or that is maybe was not captured. So we need to know if they were previously managed for pneumonia, was it the right treatment? Then in your planning, do you have any, are you planning to do culture and sensitivity for any of the pleural tap, or did you do any culture and sensitivity? Thank you so much.
Thank you for the question. The patient was managed for pneumonia 3 weeks ago. He became really better and was discharged on oral tablets. Yes. And about the culture and sensitivity, yes, it will be done together with the pleural fluid analysis.
Thank you very much, Sumaya. In the interest of time, I want to ask Mr. Solomon Alepa to be very concise with his question so that we can move on to the next part of our session.
Yes, good afternoon, everyone. Can you hear me?
Yes, please, you're audible and heard.
Yes, thank you so much for the presentation, Dr. Sumaya. Mine is just a concern on rather the examination bit. I don't know if I had it or saw it well on the slides, but there was a bit of, I think on exposure bit, you talked about shifting dullness per abdomen. Yes. And then we're talking about tension pneumothorax versus massive pleural effusion. So I just wanted a bit of clarity if it was maybe an oversight or something that you would maybe, because I would imagine would concentrate more on the respiratory examination to elicit our clinical picture for this patient. Thank you.
Yes, the patient had a distended abdomen with shifting dullness, and the abdominal ultrasound scan showed the ascites and the enlarged para-aortic lymph nodes. So we're managing the patient as a whole, not just the respiratory part.
Okay, thank you very much for your response, Sumaya. I've noticed we still have one question from Mr. Christopher Wako. I want to request you write that question down, and hopefully we can have that discussion in a later part of our session. But for the sake of time, I want to request Mr. Andrew Okiror, our pre-hospital expert, to lead us on a short section on pre-hospital recognition and what to do when you're concerned that your patient has attention pneumothorax in a pre-hospital setting. Basically, what are you going to do about it when you're in a resource-limited setting, and how can you get the patient to the next step of care? Welcome, Andrew.
Okay, thank you so much. Basically, that is that. He has already given us a brief summary of what I'm going to talk about. And we have, I think, about 20 minutes or so. I'll try to be brief and make sure I run through it very quickly. So basically, the two important things here are the recognition and what we do in prehospital care when we are dealing with attention pneumothorax. And first, I believe we all know what attention pneumothorax is, and we all appreciate that it is a serious and an emergency that needs to be handled as fast as possible and reach also the hospital as fast as possible in such cases. And most times in pre-hospital care, we present so much with those that are acute, mostly resulting from trauma cases. Those that know that to deal with a lot. Of course, there are those also that are spontaneous, but most of the spontaneous ones that come from like chronic illnesses like COPDs and so on. Usually they are gradual, and most times by the time they start presenting, these patients are already at the hospital, something like that. But of course, we have moved them also. So with acute ones, most times resulting from trauma, there are specific things that can present when it comes to attention pneumothorax. And then there are those that can also present generic. So for example, we all appreciate that when you're dealing with attention pneumothorax, there are specific things in the hospital that we try to look out for. For example, respiratory distress will be one of the key things that we just see when you interface with the patient. And there are many others features that we look out for. Respiratory distress alone may not rule out attention pneumothorax, but when we match it with other presentations like tracheal shift, that was also very distinct and clinical. You can try to palpate the trachea, you see it's shifted, the neck veins can get engorged and distended. Then other examinations like the respiratory rate, you see it's high, patient is having a high heart rate, the blood pressures are dropping, the patient is getting cynosed, and so on. So these are the pictures that we try to look out for in our patients. But also when we're dealing with trauma, we also try to consider the mechanism of injury, because we know sometimes if it is a closed pneumothorax, and they tell you that the patient probably hit the chest either on the dashboard and so on, most times a blunt trauma can bring in a closed tension pneumothorax. So when we are dealing with such, we also try to look out for the mechanism of injury. How did the patient land? What happened to the patient, and so on. Then you can tie it up and come up with our provisional diagnosis. And then also, of course, the other than trauma is what causes this a lot also is if it's a penetrating trauma, open pneumothorax, and result, if it's an open chest and so on, that can also result in attention pneumothorax. So in trauma, basically, we look at that also. And of course, if they are conscious, definitely the patient will be presenting with pain and so on. Then when we proceed ahead also with other investigations, we can perhaps listen to the chest and try to reduce air entry and so on. So these are the things in pre-hospital care that we try to look out for when we're assessing. However, in management of such patients in pre-hospital care, we really appreciate that this is a limited resource setting. You just basically have you, the ambulance driver, and maybe the relatives around, a few things in the ambulance. And you are alone, so you don't have a lot of resources, you don't have a lot of consultant. The Dr. Kabweru is in Mulago, is quite far away. So the first thing in our management is, the first thing that we think about is to make sure that how can we reach the hospital as fast as possible? That is the first thing. So this is a load and go situation, not treat and go situation. You don't have much time to waste at the scene. You have to get this patient at the hospital. So in getting this patient at the hospital, first things first, we need to be safe. Safety here is we need our PPEs on ready. Because we appreciate that even COPDs, chronic illnesses, can cause pneumothorax. So we need to have, make sure that we have our safety precautions taken seriously. You need to have gloves, you need to have masks, and so on, all those things. So that is the first thing. Then, when that is done, you can then load your patient and go. A few things we can do in the ambulance as we are going. If the chest, you've confirmed that this is a tension pneumothorax, we have a few basic emergency maneuvers that you can perform to relieve the pressure. Because now here the critical thing here is to relieve the pressure from the chest. How do we do that? First, we have to manage the precipitating cause of this pressure binding in the chest. If it's an open, sort of like a chest wound, then you need to have a chest seal to ensure that there is no escape. There is no the escape route that air takes to get from the outside to the chest is closed, so you need a chest seal. The other one, if it's a sucking chest wound, sometimes you perform a three-sided dressing on the chest. You basically pick a non-porous material. Sometimes you could use and cut, get a surgical glove, it's sterile, then you just cut it. That is also sometimes a little bit non-porous. Then you just perform a three-sided dressing. That one can create a one-way valve to try to stop the air from escaping and going through the chest, as of course you are moving to the hospital. So these are things you perform as you move to the hospital. This is a time-sensitive emergency that needs to be reached the hospital as fast as possible. So that is for managing the precipitating cause. What could be leading? What could be also the pneumothorax? And then, of course, going forward as we close the gap, moving towards the hospital, you then have to manage some of the emergency conditions that can present, that can make the patient even deteriorate further from this cause. One is, because of the high respiratory rate, one of the signs that you see, respiratory distress, it means this patient needs to get oxygen. So one of the things in our management as we go to the hospital, ensure that the ambulance has oxygen and then give the patient oxygen as we move to the hospital. The other is, as I mentioned earlier on, perhaps my other colleagues also will mention them. In trauma, these patients can have pain as well. It's important to manage the pain. That also relieves them somehow. They feel much comfortable. So you can give them some painkiller to relieve that pain that the patient is having. And then if they are conscious, most times you have also to consider the position that you transport them to the hospital. Most times, patients with difficulty in breathing prefer to even sit before even you tell them the position. So it's important for us in hospital care, allow the patient first, if they are conscious, to choose the position they are comfortable in. So if they prefer to sit, then you have to raise the coach, the gurney of the ambulance, to put them in that sitting position that they are comfortable in as we move the hospital. So That is one of the most important things to consider in pre-hospital care as a managed patient. The other is reassurance is also very important. So the reassurance in this case is to the patient, reassure them to stay calm with them in the hospital, and then also to the relatives. In pre-hospital care, we usually manage both the relatives and the patient. So reassurance is very, very important. And so then lastly, as you go to the hospital, it is important to keep reassessing the patient. And the key things you are reassessing here is the respiratory rate, how is it improving, is it worsening? The oxygen saturation, how is he improving, or is it worsening, or are you even doing anything with that? So it's important to keep reassessing that. The blood pressures, we appreciate that one of the signs in attention pneumothorax that you might see will be the blood pressures will drop. So it's important as you move to hospital to keep on reassessing the blood pressures of the patient. And then the other is that also we don't need to forget is to keep checking the level of consciousness as we move. So if the patient is talking, keep trying to talk to them, keep checking on them whether they are still awake. So it's important to be checking on their level of consciousness as you move to the hospital. So lastly, in summary, in pre-hospital care, when we are dealing with attention pneumothorax, we appreciate that it is a time-sensitive emergency. Therefore, the first thing to do is, with the limited resources, load and go with the situation. We don't have much time and be safe. Keep yourself safe, because some of these illnesses, especially COPDs, can also result in attention pneumothorax. So if you're dealing with such a patient, you have to make sure that you have the right PPE on. If it's with trauma also still, you might need PPE. You need to have your gloves on as you move to the hospital. Keep reassessing the patient as you move to the hospital and not forgetting the level of consciousness that you will assure the patient. Call the receiving facility to alert them that the kind of patient you're having so that they can prepare for you. I wouldn't want to spend much time because we need to really have a lot of time for discussions and sharing. Thank you so much.
Thank you very much for that, Andrew. It has been a very educative experience listening to your views on this. I would like also to thank the people in the chat who keep sending in their questions. Some of them are very important. I'd like to highlight something Andrew said about pain. In the pre-hospital settings, pleuritic chest pain might be the reason the patient does not breathe enough. So it's quite important to, as an emphasis for something to do outside hospital. Also, I'd like to say thank you to Dr. Mary Ellen, who is in the chat section answering some of the questions about our options for analgesia in tension pneumothorax. As Mr. Andrew finished around a minute earlier, I want to give 1 minute to the people who might have any questions to put up their hands and ask us the questions they may have. And if not, then we'll go straight to the next section about ED assessment. So if you have any questions about the pre-hospital section of this, would like to hear from you right now. But since I don't have any hands up, I would like to start preparing for the next section, which is ED assessment. Basically, what are you going to do about these conditions after Mr. Okiror has given you that call that he's bringing you a patient who might have a massive pleural effusion and intention pneumothorax. So while we await those questions, we're going to load up our presentation so that we can have our expert session on what to do in the ED and within the hospital setting.
There's one raised hand.
So Niwamanya David. you have a raised hand, you have a question, please unmute and let us know.
Okay, thank you so much, and I'm glad for the explanation. My question, he talked about the ambulance management, where I just needed him to continue to clarify. Sometimes this patient has already been done an underwater seal drainage. They have the thoracocentesis cube in, and you want to transport this patient for further management, maybe in a regional referral hospital. And there is always a very high risk. Maybe the nurse who is accompanying this patient the cube might get off. So I just request him to clarify to us what basically can we do if we are going to transport this patient who has been referred to a regional referral hospital, and they already have the cube inside. Thank you so much.
Thank you so much, David. It's a very relevant question to the management of a patient with attention pneumothorax or an effusion, especially after we manage to get a chest tube in situ, because it changes the physiology. We hope to answer your question within our next 2 sections. We're going to have a section on hospital care and then the nursing care of this patient.
I should just make a small comment about that question. Usually when a patient has a chest tube in and during transit, we recommend the chest tube to be clamped. And they do intend that complications are imminent to happen. For instance, if the patient is on board moving from one facility to another, we recommend the chest tube to be clamped because it may be dislodged, or it can even injure and kill the patient if he's not well situated. But also during transfer from theater to the ICU, and we are putting a chest tube, because air is most likely to build in, and actually it may cause more havoc than harm. And also the other thing that sometimes they built in and it will suck in air. So it is better to clamp even when the patient is going for investigation. For instance, he has a chest tube in, but he has to go to the Department of Radiology to do a scan or a chest CT or a check X-ray. So during transit, we recommend the chest tube to be clamped. That's the ideal. Unless if you're moving with a person and is going to take care, but anything can happen on the road or somewhere. So the best alternative and opportunity is to clamp as you move the patient.
Thank you very much, Dr. Kabweru. I hope that answered your question, David. It's a very good question and a very clear explanation from our expert. So if we don't have any other hands raised, I would like for us to move to the next section of our session today, which would be the EDSS. All right. So moving on to the next section. This is the outline of our next session on this. We're going to look at the ED assessment. So first, we're going to look at the nomenclature and anatomy of these things, of this condition, because it's important to understand exactly what is going on with your patient, what you're going to do in the first 5 minutes, how you're going to diagnose the condition, the management strategies, and some of the follow-up we'll do. Some of that will also take us into our next session on nursing care, and some special considerations in certain patient populations So moving on. Pneumothorax, basically, it's an abnormal, it's a presence of air within the potential space between our two pleura, the viscera and parietal. It is a pleural effusion being a collection of fluid within that same space. That space usually has some fluid, and a pleural effusion is basically when we have an abnormal collection of it. Something which goes anything beyond 20, around 10 to 20 mils of fluid within our pleural space would qualify as an effusion. A massive pleural effusion is an effusion in which we have a mass effect due to this fluid within our pleural space. So this increase in fluid or air causes a change in physiology due to the pressure it exerts on our lungs and our intrathoracic organs. So as you can see in the image in front of you, you just have our inner space where we have a visceral and parietal pleura. And if we have air getting in there by any abnormal mechanism, then we'll have a pneumothorax. A pneumothorax may be spontaneous, and among the spontaneous, it may be primary or secondary. As you can see in front of you, a primary spontaneous pneumothorax would be one without a triggering event, and a secondary one would be secondary to something else. That being another condition that would cause an injury to the lungs or an air leakage from the lungs or our intrathoracic cavity, into our intrathoracic cavity. Trauma is a very common cause of this, and many tension pneumothoraces come in due to trauma or traumatic causes. Moving on, pleural effusion. So as we said earlier, it's an abnormal collection of fluid within that same potential space, and which has very many causes which are important to distinguish. But the mainstay of distinguishing the causes of this fluid lies within its analysis. So for the sake of this discussion, we shall look into those causes a bit later. So attention pneumothorax, what is this? So attention pneumothorax is that life-threatening condition that presents when this abnormal collection of air causes hemodynamic instability, also known as hypotension. Secondary to that displacement of structures by the air. And when you have this displacement of the intrathoracic structures or an increase in intrathoracic pressure, the preload on the heart will be reduced. And through principles like Frank Starling's principles, when we end up with this reduced preload, eventually the cardiac output will come down. And when we have that reduced cardiac output, then we're going to end up with a patient's hemodynamic status being compromised. And eventually they will not be, we will end up with a tension physiology. And that is how a tension pneumothorax is distinguished, one, from a pneumothorax, which is large, and two, how it causes hypotension. So when this patient arrives in the ED, within the first 5 minutes, what are we going to do? The very first thing we're going to do is a primary survey. And a primary survey is designed in a way that it should pick out life-threatening conditions like tension pneumothorax and pneumothoraces very quickly. But just going through it quick, of course, airway obstruction is quite important. When a patient has a pneumothorax, sometimes they may present with subcutaneous emphysema, which may or may not compromise our airway. Breathing support is a mainstay of treatment. As Andrew alluded to, we give oxygen, we supplement oxygen for patients with compromise in their intrathoracic cavity or within their pleura. Circulation, disability, and exposure, as Dr. Sumaya looked at, and it's important never to forget glucose in any emergency or critically ill patient. So on examination, many times patients will come in complaining of pleuritic chest pain, but when you get down to examine them, the most common presentations in the ED will be air hunger, shortness of breath, and tachycardia, because depending on the cause, this is a patient who will be in pain, and they will not be able to breathe well due to inadequate lung expansion on the side on which we have either the abnormal air or fluid collection. Abnormal or unequal chest wall movements is a very common presentation, because the expansion of the lung on one side will be affected by the fluid or air. Because of pleuritic pain, they may present with rapid breathing or tachypnea. They may present with an abnormal breathing pattern because they're in pain. Because we have something causing a mass effect or a pressure shift, then it's very common for them to present with a mediastinal or tracheal shift. They may have hyperresonance or stony dullness to percussion, depending on whether they have a pneumothorax or an effusion, respectively. We will notice abnormalities in vocal fermitas, and we will have decreased breath sounds on the side which is affected. As Andrew alluded to, the absence of these does not exclude the diagnosis, absence of any one of them. So it's important to maintain a high index of suspicion for any patient who has an etiology that may lead to this presentation. So because of the limitations in our setting, different investigative modalities will be present to you in different hospital settings. Bedside lung ultrasound has been proven in many settings as sensitive or almost as sensitive or more sensitive than chest X-ray, especially when you're in a condition that you do have an ultrasound and X-ray might require further logistical support for the patient. So it's important that we all know about this and that we may advocate for it in our settings, that we may do lung ultrasounds for it. This is just a quick summary of what you're looking for in ultrasound of the lung when you are suspecting a pneumothorax. So the movement between the lung, the two layers of the parietal and visceral pleura leads to something known as lung sliding within the chest. And it's the first thing we look for. However, in every patient, in any normal patient, during a lung ultrasound, there will be those white lines on your screen, labeled on your screen as B lines, and they should move with respiration. Absence of movement or absence of said B lines should increase the index of suspicion for pneumothorax within the patient. There are also something known as A lines, which are horizontal lines which are visible in every lung. They're supposed to be equidistant and clearly seen. If they're not so clear, then it also should be something that should increase your index of suspicion if you have a lung ultrasound available. The two images at the bottom just show what the normal appearance should be. The one on the left being what is known as a seashore sign, which basically looks like a seashore where at the point at which the water meets the land, and presence or absence of this indicates absence of this would increase our index of suspicion for a pneumothorax. So it's also quite possible to pick up an effusion on point of care ultrasound. And when we're looking at a pleural effusion or looking for a pleural effusion on ultrasound, then it is very important for us to obtain a view from the right upper quadrant of the abdomen. But in this, we're basically looking for fluid above the diaphragm, which would be anechoic on ultrasound. And you want to just look at how much, we want to look for fluid above and below the diaphragm and quantify by looking at the distance between your diaphragm and any normal lung that you see on the ultrasound. Plain radiography is the mainstay in most of our hospitals for diagnosis of pneumothorax. However, I should point out as we move further that attention pneumothorax and massive pleural effusion being emergent conditions that threaten life, a clinical diagnosis should always be your priority, and you should not delay management to do any of these steps. But moving on to a plain radiography, when we're looking at a plain radiograph of a patient with a pneumothorax, there's a couple of things we want to look out for, and many of them are very. It's something that's very important for us to know. So there are certain markings we look out for. Number one being a pleural line, basically delineating the point at which the lung parenchyma ends, and we have a gap between our lung parenchyma and our chest wall. So we look for what we call the pleural line, its distance from our from chest wall. Many times we have sick, critically ill patients who present and they cannot stand up, or they may have a chest X-ray done in the supine position. So the image in the middle of your screen shows something in the corner. It's just something just above the diaphragm in the right lower lung zone. That is something known as the sulcus sign, and it basically comes from it basically presents in a patient for whom a chest X-ray is done in a supine position due to an air collection upwards above the lung. Moving on. It's possible to do size estimation for a pneumothorax. However, when you're suspecting attention physiology, estimation of size should not be a priority. However, it's a quite useful thing to do. You can do it by measurement of these parameters, as you can see on your screen, A, B, and C on your X-ray, and you use that to determine a percentage and size of your pneumothorax. So this just shows where our pleural line is and the distance we have from the chest wall. So a large or a small one would be anything above 3 centimeters. So this is just the deep sulcus sign and a pictorial projection of what we were talking about earlier. This is how the air will collect upwards above the lung in a patient in a supine position. So it is quite useful to know. It's something that's useful to know and be mindful of when you have a patient presenting in with pleuritic chest pain and you're suspecting attention pneumo. This is something we might see if you do your X-ray in a supine position. Computed tomography. So CT scan is the actual most accurate method for detection of this because it has the ability to distinguish between certain tissue types, gas and fluid. However, its availability in our setting is not so ubiquitous. So moving into the management area of this, oxygen therapy is important. Supplemental oxygenation of any patient with whom you're suspecting attention physiology, like a massive effusion, is very important, maintaining our saturations above 90%. And then the mainstay of treatment is thoracostomy. As we said earlier, thoracostomy should not be delayed in the name of investigation, since this is a diagnosis that should be made based on history and clinical examination. So it's basically a procedure in which we place a chest drain through the chest wall to drain the pleural cavity. And we do it in pneumothoraces and pleural effusions. It is the mainstay of management to relieve pressure and save life. It is also the answer to the question of what we do about the hypotension in a patient with a pneumothorax, because that is the way to treat the cause. When we're doing thoracostomy, ATLS recommendations recommend that we target the triangle of safety, and it's delineated by just the image you see in front of you. the borders being the lateral edge of the pectoralis muscle, the base of the axilla, the fifth intercostal space, or what you can, or the nipple line. The nipple line could also be used as an analog for that line. And then our lateral edge of the latissimus dorsi. So that is the region in which it is safe to place a chest drain. And it is the area with the most safety. Well, chance of having adverse conditions. ATLS guidelines have encouraged prophylactic antibiotics. However, this should also not be something that delays treatment for a patient. However, giving antibiotics to any patient for whom you're placing a tube is important to prevent pneumothorax, which is a very serious complication that we usually get when we're not mindful of sepsis. Sedation and analgesia is important for this patient because you do not want a patient fighting you while you're trying to place a tube. And it also improves their respiratory effort. So insertion techniques of this, there are different schools of thought. I think when Dr. Kabweru was training, the trocar method was something which was highly used, but slowly by slowly we're using it less and less. However, it is something that you should always keep in mind as an option, but it presents with a higher incidence of organ perforation or damage to the intrathoracic structures. Also, the approach to the insertion or incision is very important. The more anterior you make your incision for thoracostomy, the higher the chances of failure because the chest wall becomes thicker the further anterior you get. And it also might be a complication in a patient who has a left-sided pathology because you have the heart there and you may cause other complications of direct stimulation of the heart, like dysrhythmias. So recommended sizing for chest tubes for any adult patient, ATLS guidelines for the averagely sized patient recommend 28 to 32 French size chest tubes for treatment of traumatic pneumothorax. This suffices also in the side of massive pleural effusions. And in case you're not sure if there is blood, it usually is large enough to drain any blood you may have coming from the patient's primary pathology. Finger thoracostomy is something that is being fronted regularly among emergency medicine practitioners because it provides a very reliable way of knowing that you're in the pleura, and it also presents a lower incidence of traumatically injuring the organs underlying due to sharp curettage or sharp incision methods. In front of you is just a pictorial explanation of the procedure of bluntly dissecting through the chest wall in order to place a chest drain or a chest tube, perform thoracostomy. So just moving through it real quick, you can see in image A, we do a sharp dissection of the skin. Image B, we'll tunnel into the space using artery forceps or an equivalent piece of equipment. And using our finger, we shall guide that forceps into the pleural space. And once we have confirmed that we're in the pleural space, of course, while maintaining sterility, then that shall be the moment in which we shall use that same forceps with our fingers to guide the tube into the space that we want it to go into. There are many ways of securing the tube, but it's very important while you secure the tube or after securing your tube to make sure you tug on it, to make sure it's well secured and it will not slip out. This prevents complications like the ones we have asked about during patient transportation, during patient care in the bed, it will help the patient it will help you and the patient not to worry about dislodgement during further patient care. So post-placement of any tube, it's important to send fluid for analysis in case we have fluid, and we're going to look at why that is. We monitor and document initial drainage, and well, if the patient has been having a tension physiology for a while, then it's important for all people placing a chest drain to be mindful of re-expansion pulmonary edema, which we're going to talk about a bit later. It's advised to clamp your tube for a period of time if you have a patient coughing, but also to be watchful for how much you're draining. If a patient has a drainage of greater than 1.5 liters in a day, then it's also taking us to a risk of re-expansion edema. So when we have a patient with pleural effusion, it's important for your diagnosis to distinguish, to find out the source of this effusion, of this abnormal fluid collection. And when we're trying to distinguish this, we use Light's criteria. Basically, we're going to send out fluid for analysis, and we're going to look at protein, LDH, and we're going to compare these two parameters within the serum of the patient and the fluid we have drained from our effusion or from the intrathoracic cavity, and that will distinguish whether it's transudative or exudative, and will help us zero in on the potential causes of this abnormal fluid collection. The objective of this talk was not to talk too much about causes. However, it's very important that this is done initially, because some of these conditions may present with other complications that may lead to increase in mortality for the patient. This infographic is just a very easy way of remembering the difference between transudative and exudative effusion. If it's low in protein and LDH, then most likely you have a transudative, and if it's high, then most likely we have an exudative cause. A thorough history and exam is very important, because as we can see on your screens, the number of conditions that can cause this are quite varied and many, and the primary issue might not always be in the chest. So moving on, underwater seal drainage systems. There are many various systems. Some come pre-made, some of them are improvised. What you see in front of you is just a product known as a pleural. It's a pre-made underwater seal drainage system, and these are not so available in our setting. But since we are trying to improve ourselves constantly as a country, it's important that we know about their availability. Among the improvised systems, or among the other types of systems, there exists different configurations. So we have a 1-chamber system, a 2-chamber system, and a 3-chamber system. All of these will go under the water seal, and the length, the depth to which we place that tube is also quite important to the effectiveness of our underwater seal drainage system. So that tube under the water is the seal that we are putting underwater. So it's not an underwater seal drainage system unless the tube from our patient is under a water seal. So in an ideal setting, it is possible to place suction for a patient with an underwater seal drainage system. Our recommendations are a maximum of -10 to 20 centimeters of water. That would be the level, and to improve drainage of our effusions. So speed of drainage, as we alluded to earlier, it's important to clamp our tube so that we do not have too rapid a drainage of an effusion or a pneumothorax, depending on etiology. And this is mainly to prevent the re-expansion pulmonary edema, which is a very serious complication when our lungs expand too fast following the period under tension. So any patient who comes in with a significant mediastinal shift, intermittent drainage will be very important. So complications of this are wide ranging, and they can present at very many stages, but many of them will present, some of them will present in the patient due to the pathology, and others will present due to the procedure and the changes in physiology that procedure has caused. But some of them have some obvious ones would be very bleeding, hypoxia, because you have a patient coming in with air hunger. You could also have dysrhythmias, hemoptysis. There are many patients who may present with drug and allergic reactions. But as Dr. Kabweru alluded to, we can have a tube leak. This may be either due to faulty connections, improper sizing of the tube. Sometimes you can have tube loss when your securing of the tube was not effective. You could have improper positioning of the tube due to misinterpretation of your images or your findings. Sometimes we may have also issues with the heart, like dysrhythmias. As I mentioned earlier, it's important to be mindful of where your heart is in relation to when you're in relation to your tube during placement. An improper skin incision that may lead to a horrible scar or a wound. Surgical site infection is a very common complication of tube placement. And if we have an improper setup of the underwater seal drain, then our tube might cause more problems, may cause more harm than good by being a channel through which air enters our intrathoracic cavity. About re-expansion pulmonary edema, it is a life-threatening condition that arises after rapid re-expansion of a lung. Most times it comes after like 2 or 3 days of being under constant tension. However, as we saw in the beginning of our discussion, these are life-threatening issues that cause that cause hemodynamic instability. So we might not always have so much time. However, anyone who's going to place a tube should be very mindful of this and be prepared to escalate care if needed. We can move from this one. So following up any patient with a tube is important. It's important to do a daily assessment because as we saw earlier, we are changing physiology. So we need to reassess our system daily to ensure it's not causing issues. We need to reassess our tube daily to know that we are having one, an active drain, but two, that we're not causing further worsening of physiology, either through attention physiology when we're clamping for too long, or a re-expansion edema from draining too fast. Daily imaging is not necessary. However, if you want to reassess the expansion, then at a maximum of around 4 days should be a good timeline to see. 3 to 4 days should be a good timeline to reassess for expansion. So special considerations are among patients with things like pregnancy, a patient who comes in with who seems unstable, even with your tube placed, might have a persistent leak. And these are the patients in whom you want to consult cardiothoracic surgery and consider replacement of that tube. So disposition of these patients, it's important to know where you're sending your patient afterwards. But any patient for whom re-expansion you can prove re-expansion by radiography, may be sent home through clinic. And all patients who come in with a large effusion or an empyema should be admitted to hospital for a further workup. Thank you very much. So I'd like to invite Dr. Kabweru to just sum this up for us, so that we can move on to the next section of our discussion.
Thank you very much, Dr. Jonathan Mugyenyi. You have done the best to discuss tension pneumothorax and the massive pleural effusion. I just want to go straight on, I think, 5 important key things. One, diagnosis of both tension and then pleural effusion still remains on 2 things. It depends on the history and physical assessment. So I expect each and everybody to have a stethoscope and listen to the chest. Percuss, and then know what you're percussing. Tension, pneumothorax, you will get hyper-resonant sound, whereas pleural effusion, you get tonedal. Sometimes you may get confused whether there's fluid or consolidation, but those are very few things. When you listen, sometimes there's no breath sounds in both. So people have to know. Whereas if you are examining, you need to look for the trachea. In both situations, the trachea is pushed the opposite or its lateral, the opposite side. If the tension pneumothorax is on the right, and massive pleural effusion also happens to be on the right, not in the same patient, then the trachea is displaced on the left, and even the mediastinum is also moved to the opposite side. So unless if there is a consolidation or a tumor or something, but in massive tension, that will happen. So it is always very important to rely on your diagnosis on those 2. But to confirm and also to make a follow-up after interventions, it is important to follow up with imaging. And we have already alluded to ultrasound scan. Actually, focus should be the best point of care ultrasound scan that is done by almost every individual. If you have picked the skill, it is very easy to do and interpret. And we are not saying that the radiologists shouldn't be there, but we are saying that we just want to improve care as soon as we can. And then chest X-ray is very paramount, and the erect chest X-rays are very to interpret even to most of the people who are not radiologists. But when it comes like to massive pleural effusion and you have a spine X-ray, it may be a little disturbing for you to assess. If you're planning to do any other follow-up or intervention, then a chest CT will be able to make for you the best diagnosis if it is follow up with the massive pleural effusion after drainage, so that you identify what the most likely cause should be or is, or you intend to drain the surgeries. And then the complications, he alluded on the re-expansion pulmonary edema, RPE. Actually, how we mitigate that is that we usually carry out what we call intermittent chest tube drainage, whereby we allow the patient to drain like for 30 to 45 minutes. And this patient, remember, is on oxygen therapy. And then we actually clamp for a period of around 4 to 6 hours, 4 to 8 hours, depending on how stable the patient is. So oxygen therapy, when it stabilizes and it's calm, then we release until actually the lung keeps on expanding slowly. Otherwise, if you release the fluid, you remember like massive pleural effusion, we are talking about liters of fluid in the chest, between 45 and more. So if you just drain and drain endless, actually this patient gets RPE, and the patient may not give you an opportunity, but the patient may easily pass on because of air hunger, and you may not save that patient. So let us be cognizant of what we are doing, and if we don't know, some of us, our phone calls are 24 hours patent and charged and willing to respond. Even when you call from up country, we can always answer. Also, I just wanted to make a comment about improvisation. I really don't want to improvise, because The commonest cause of most of these complications, like pneumothorax, is because most people are using wrong equipment to drain most of these, most of the pleural effusions. But by and large, if you're stuck and then you want to help this patient, I would recommend we put a catheter size 24 in the chest and secure it, and then refer the patient. Mulago is not in UK, Mulago is in Uganda and in Kampala, and it is almost in the center. So wherever part of the country you're coming from, you will reach in less than 12 hours. That means if you are in the farthest points, so we are ready available and you'll be received, and Kabweru works 24 hours and we have teams to help. And the other key important thing is that after drainage, I should talk about the tension pneumothorax. You put a needle thoracostomy, you put a needle in the second intercostal space, like a mid-axillary line. That line that passes through the clavicle, middle clavicle area, and then the nipple, and then the anterior superior iliac spine. That's where you put in the second intercostal space. Remember, your lung is collapsed, so you're not going to cause any damage to the lung. It is a way, it collapses towards the high lung, towards the medial end. So when you put your needle there, it is going to give a gush. But the challenge, we're having two things. You have hypoxemia, oxygen levels are low, but also you have hypotension. So you need to insert the chest tube after putting that needle thoracostomy, so that actually you allow venous return to the heart. Otherwise, if you don't do that, still this patient is going to die because of obstructive shock, whereby the heart is not filling up, is not allowing blood to come back to the chambers to be redistributed, or to be reoxygenated in the lungs and then to be redistributed in the body. So always call, and I usually insist, consult and consult and consult. If you feel you can't refer the patient to the patient cannot reach alive. Massive pleural effusion. As they say, massive, after drainage, sometimes we have to do daily checkup. How much are you draining the effluent in 24 hours? And two, you keep listening whether the lung is expanding. And three, radiologically, you want to do daily check X-rays if they are affordable and available, and they should be able to show you how the lung is expanding. Now, if it comes to some of the conditions, like if someone has cancer in the lung and there's no lung filtration, but the drainage is going to be continuous, we prefer to insert what we call a pigtail catheter, which actually the patient can go with at home and it continues to be to drain at home, because some of those patients drain for months and months, if not years, if they are still alive. And sometimes you can't put in our chest tubes that are quite huge, 30 size or 36 for pass, which they are quite very huge and they are uncomfortable. And you wouldn't want to introduce infection in that kind of patient. Now, if the drainage, you feel it is less, and now this one goes to the recurrent pleural effusions or malignant effusions. Sometimes if the lung has expanded well, we go and put in a sclerosant, what we call pleurodesis, and we occlude the space between the parietal, that is the chest wall, and then the visceral, that is the lung surface. So that surface comes, closes off the place or that space that usually has that fluid that keeps accumulating. And that can go a long way actually to like help your patient to be managed better and have a quality life. However, if all those fail and this patient doesn't have pneumothorax, and it is already in the organization stage, that is the last stage, he has passed in there, we end up doing a thoracotomy plus or minus, thoracotomy plus decortication, and if the lung is not able to expand, we may end up doing a lobectomy. We remove a lobe or lobes if it's on the right, or sometimes we may end up doing a pneumonectomy if it cannot expand and it's perforated. So some of the complications that we have received and done and worked on in Mulago is because we improvise a lot. Yet if we use the appropriate equipment or tool, we'll end up actually having so many patients saved. And the other thing, the other problem that I want to allude on too much, the commonest cause of all these two, tension pneumothorax and massive pleural effusion, apart from the infections, malignancies, and others, is trauma. And we should remember that actually, apart from abdominal trauma, neurotrauma, chest trauma is the third commonest cause of morbidity and mortality in this country. And surely, if you have a patient, whether you are fallen from a tree or from some things at home or fallen from a height 10 meters, or all people who fall with other lung pathologies, please, if you really can get an X-ray or an ultrasound scan of the chest and abdomen, refer that patient. And I want also to answer the question about gut perforation and splenic injury and tension pneumothorax. I want to advise my colleagues that actually, if you have the best anesthesia team and someone has any pleural collection, put in the chest tube, and you can go and work on the patient on the gut. For some of us who did med, we can open the abdomen and other parts of the body with ease. So if you find it difficult, please put that chest tube in there, and the person is able to get anesthesia as they even close the monitoring, whether it's raining and whatsoever, and proceed to do a laparotomy and achieve hemostasis. You may end up doing a splenoral effect if you can repair, if it is injured, if it's type 1 or type 2, actually type 2 splenic injury, you can do repair. Type 3, you may wait, also splenograph may do. Type 4, you may need to remove it, and if type 5, if it's still alive, because that is almost splashed, and with vascular injury, then you can remove the spleen and then achieve hemostasis. Repair your gut, and depending on the cause of the injury. If it's gunshot wounds, then you may need actually to resect, and you may not necessarily primarily anastomose because you don't know the extent of the damage. Whereas if it's normal trauma, you actually resect as farthest as the pink gut or viable gut, and primarily anastomose. So in trauma, you need to be the best at your game, so that at the end you get a life, and a live patient with less complications. Otherwise, I want to end it there and give people floor to ask questions and give answers. Thank you.
Thank you so much, Dr. Kabweru, for that. We wish you did not have to stop, because we know the things in your head we cannot get enough of. In the interest of time, I'm going to push the questions and answers to one of the final sections of our discussion today. I would like to also say a special thank you to Dr. Makerere for answering some of those questions in the question and answer area in our chat. I would also like her to also prepare that we shall have a session on that a bit later. So we'll keep the questions and answers to that section with Dr. Makerere a bit later. And now I would like to invite Mr. Mwesigye Julius to give us his talk on nursing care of a patient with a chest tube, and hopefully answer all the questions that we have, any that Dr. Kabweru may not have answered so far. Thank you very much. You're welcome, Julius.
Okay, thank you very much, Doctor. I also want to thank the Seed Global for inviting me to give my submission about the care of chest tube. First of all, as you know, our patients, we care as whole, not specifically for that condition. First of all, as a lot of the nurses to create rapport with this patient. As you know, creating rapport with the patient is very, very important, so that the patient can gain comfort and trust in you. So as earlier on, our discussants have mentioned, this patient has chest tube in situ, needs to be positioned in the right position. And the right position, we prefer same forward position or sitting up position, or you put the patient in 45 degrees. That position, it allows drainage of the fluid that in the lungs. Basically, we have like 3 things to talk about in patient with chest tube. One, we look at the insertion site where the chest tube has been put. Secondly, we look at the underwater seal drainage. And the third, we look at exercise. These patients need more exercise to make sure that their lungs expand and they require and expand very well for easy recovery. So if you can start with the insertion site, we are the role of the nurse is to assess the site for pain, for signs of infections, for cryptas. You know that time when the air escapes into the subcutaneous tissue, when around the site, you find it is a bit perfect. When you palpate, you feel crackles. So after identifying the pain, if there is any infection, whether there is infection or not, we have to dress this wound. But in the first 24 hours of surgery, we don't tamper with the dressing. So we dress the next day, and then we dress intermittently. If we dress like today, we miss tomorrow, and then we dress the other day. As you are dressing, observe for signs of infection, pain, and then we administer, as it's our role to administer drugs for these patients. Because they have pain, we have to administer painkillers, we administer antibiotics to make sure that we calm down any infection, any pain, so that the patient can feel okay. In our discussion, we talked about underwater seal drainage. We have 3 systems. We have one bottle system, 2 bottle system, and a 3 bottle system. If my friends if I can show you the one that we are having here, we have this one. This one, you can call it one bottle system because it has the correction. This one is just an addition because this one is this is 900 mils, but it goes to 100, like that up to 200. So this one is a bottle, this is a drainage tube, and this is a test tube, if you can see it. They have numbers as Dr. has been mentioning. So when we are draining, here, down here, it has what we call initial level. We have to put water up to this level, the initial level, and you see this tube. You see it goes, it reaches there at the level of the initial level. Initial level. It is not up, but it is on initial level. I think you can see it's there. We are around there. So when we are going to insert, we put water up to sterile water. Can use normal saline or sterile water or distilled water up to that initial level. I don't know whether my camera can reach there, but up to that level.
That blue line down there.
Yes, the blue
Line down there.
mark around here. So put water up to that end. So when you insert your tube, it goes up to that level. Why? We don't want to, when we insert in the chest of the patient, to pull air into the chest. That is the rationale for that. So this is our drainage tube and the suction tube, as I told you. So
the chest tube here has something blue that we use to connect it.
Yes.
The connector here.
Okay.
So when we insert it, this is the connector that we put in there, and then the sterile chest tube will connect. So people will be able to see this one.
Yes. So it has in the connector, you can remove it.
So this is the end that we actually put in the chest, in the patient's chest. This is a sterile chest tube, and this one is size 26, which you actually can be able to drain a pneumo comfortably well. And when we cut off this side, then we connect the connector and then the chest drainage, and I'll through the other side. And this actually we put it in the patient's chest. It has measurements depending on the thickness of your chest. But we know that the chest, if you want to estimate, and you're going to put it in the, and these are around here in the 4th of 3rd of 15th intercostal space, we can just use that estimate, that length. By the time it reaches the angle of Lewis here, that is enough length for you to actually put into the posterior. You push it in posteriorly. If you want to drain fluid, you direct it inferiorly. But if you want to drain air, then you direct it superiorly. So it is posterior, superiorly for air, and then posterior, inferiorly for fluid. You know that fluid is denser than the air. So when you're putting, don't just push it across the chest. And what my brother, Dr. Jonathan talked about is the trocar, that there is a new chest tube on market that actually has a metal. We are not meant to use that one when you're putting a chest tube from out. That one, we usually use it when you have opened up the chest during thoracotomy. So we direct it away, it is to pierce away out. But if you want to put, actually we have ever gotten a patient from up country, I'll not mention the unit, where they were using that trocar chest tube, and they pricked the esophagus, and we had an esophageal leak. That girl worked on her after like 3 weeks because she was eating things and they were going into the lungs. So she presented with a pneumonia and with the food leaking into the pleural space on the left. We worked on the child and then referred back the child. But those injuries shouldn't have happened. So we need to know that this is safer for you to use. And these chest tubes are available on the market between 10,000 and 30, depending where you're buying them. 10,000 to 30. So please don't mutilate somebody's chest by putting wrong things and claiming they are not available. They are available. And Mulago has so many, but because of the higher numbers, sometimes they will get stockouts. But they are available in market and they are affordable. And everybody in this Uganda can try to afford 10,000. Thank you.
Okay. Thank you very much, Dr. Kabweru, for that explanation. So we have talked about the site insertion of site and the underwater seal drainage. Still, in the underwater seal drainage, if it is connected to the patient, there are many things that we have to observe, like amount, the normal amount of fluid to drain. Ideally, it should be 100, 200 per hour. The normal, so if it exceeds 200, that means maybe there is an injury somewhere. So you'll have to call the surgeon to come and review. The car also can be dark red, can be clouded. By the normal color, when you see that the patient is improving, the normal color should be serous fluid.
Serous fluid is pale yellow?
Yes.
Okay, yeah.
Yeah. And another thing, that's what I talked about, that you should make sure that the seal chamber has water at the level initial, so that the patient does not fall in or air. The third thing that we must emphasize is about exercise. These patients, immediately after inserting, they should start exercise within 6 hours after controlling the pain. This patient, if they're going to do some exercise, we should first give them painkillers to control. You know, it is painful. There is a wound, there is an injury already. So if you don't control pain, the patient may not be able to do these exercises. Which exercises do we mean? We mean the deep breathing exercises. You may instruct the patient to take a deep breath, breathe out, deep breath, breathe out, or a patient may use a spirometry. This one.
Called an incentive spirometer.
Yes.
So you actually, I tell 3 balls, the red, yellow, and green.
Yes.
So someone holds it at the level of the mouth.
So if you want to instruct a patient, of course you have to instruct when he's seeing. You don't just give and you know you are going to use this one and you just let the patient go. You must train this patient. Otherwise, you just put it under the bed and say, "I'm so told me. I'm going to use this one, but I don't know how to use it." So you tell the patient to put this spirometry at the level of his or her mouth, and then puts this in the mouth. But before, a patient must exhale air, and then put on the mouth, a deep breathe, like this.
And then you pull. You see,
even me, one is not going, but the patient must continue. Of course, the first attempt, he may not be able to raise all of them, but they are supposed to be raised all of them at the same level. But as the patient continues to do that exercise, these balls will raise. If he fails 1 or 2, he continues.
So until you are able to raise, now that is a very good one. And it is important why we say to control pain, because in most cases what we have realized that when people put the chest tubes into the chest, they leave the chest tube hanging. But what we recommend these days, as you put the chest tube, you put a mesentery. You put a plaster, close the chest, and doesn't pull on. You avoid point pressure. So at the end of the day, when the patient is doing this exercise, he doesn't feel pain. It looks a simple exercise, but it's very tough. It is only athletes who blow those things in a quarter second. But if you're normal Ugandan like my friend here and me, you take some little drink and then you do the exercise. So otherwise, it is very important. And these are some of the chest physios we talk about, chest physiotherapy. You use an incentive spirometer, but even walking. Those are the starting points. Walking on a flat place for like 6 minutes or less or more, or until when you feel unwell, is what we recommend. And then 2, step ladder. Sometimes they use steps. And it looks like you're going to move 5 or 6 steps, and if you feel unwell, please take a rest, and then till you are able to come down and then rest. But otherwise, when you just tell somebody to do exercise, sometimes Kabweru's exercise may not be for Jonathan or Dr. Thomas or the rest. So you tailor according to the patient you have at hand, and always ask them to take rests in between, even when it's just using the incentive spirometer. Otherwise, don't ask the patient to use the incentive spirometer until he collapses even on bed. Thank you.
Yes, thank you very much for that addition, Dr. Kabweru. Another exercise you can tell these patients, coughing exercises. After inhaling and exhaling, you tell this patient to cough at least 3 times. And this exercise that he's doing, should do it at least 10 times in like 1 hour or 2 hours, and then he will see the improvement. So lastly, I'd like to talk about, I said we treat patient as a whole. We can't leave out nutrition. So nutrition also is very important, basically protein foods. Thank you so much.
Okay, thank you very much, Julius. We would like to go to the final 2 sessions of our discussion today, which are quite linked. I'm going to ask Dr. Mary Ellen for any questions of note she might have noticed in the chat. Also, anyone with a very burning issue for our experts, this is your best time to ask. Please put up your hand while we still have a moment to answer your questions.
Yeah, I have this is Dr. Mary, a couple of questions here that I thought the panel might be able to address. One was someone was asking how we could anticipate reinflation syndrome or how to manage it if it does occur. And then someone asking if we could throw some light on the procedure of chest tube removal. And then Christopher Waco had a couple of very interesting questions that perhaps he might want to chime in and ask himself, but asking, for instance, when there's no oscillation in the tube, what the next step, would be.
Okay. Thank you very much, Dr. Ellie Mary. First of all, I want to comment on when you have the re-expansion pulmonary edema, it is the one thing that I've faced, and I wouldn't want any of you to face it, because the patient actually becomes breathless, and in most cases, people don't know that they are draining, and they continue draining. So that patient, how we manage the patient, one, we had to clamp the chest tube, and we stopped the drainage. Two, the patient was put on oxygen, and then three, we introduced some small dosage of diuretic, 2.5. It shouldn't have, but we put in something, because that chest pulmonary edema is quite very difficult when it sets in. And then we gave this patient also IV hydrocortisone, 200 milligrams was an adult start dose. And actually that entire day we never drained until the next day. But it took a lot of time to stabilize. But the other thing that actually I've lost around 2 patients, the same. And actually they end up coughing blood until they will pass away, even when you connect the oxygen therapy. So it is not something that is very good that if it happens, I wouldn't want to see it, but if it happens, that's what you can try to do. But how to avoid it? If you have massive pleural effusion, please just stick to the standards. Drain for 30 minutes, stop, rest for 6, 8 hours or 12 hours, wait until the patient is stable, and keep monitoring SpO2. That is very important. And then chest removal. Chest tube removal, I alluded on it politically in the first statements, where I said that actually you keep assessing the patient. You listen to the chest, but also you look at the radiological findings. If the lung is expanding and you are drainage in 24 hours, because I ask that thing every day I come to Casualty in Mulago, how much have we drained? And if that answer doesn't exist, I take the patient to my ward, because I need to chart how much I'm draining in every 24 hours. And if it is pleural effusion and you have less than, sometimes people say less than 100 mils, but less than 50 in 24 hours will be adequate enough for you to remove if the fluid is serous or pale yellow or clear. But if it is another color, if it is pus, you don't need anything in the chest. You don't need any little pus, even a drop. If it's blood, usually if there's hemothorax, you make sure that by the time you remove the chest tube, you have that blood discharge is out, and then the effluent is clear or pale yellow or serous. And if it's less than 50 mils collected in 24 hours, then you are good enough to go. Now, during the process of removing the chest tube, you ask the patient to breathe in, hold, and then you remove the chest tube and seal the stomach, so that at the end of the day, you don't end up with a pneumothorax. But also the other thing is that when you're putting your chest tube, make sure all the holes are within the thoracic space. Otherwise, if they are in the tissues, you actually end up causing a subcutaneous emphysema, which can be extensive and even reach an extent of causing mediastinal shift, and even worse than what you're correcting earlier. So I'll just stop at that. But we maintain to do a demonstration later on, around 1 or 2 hours, and then we see how well we can do that. When you don't see a meniscal swing, what is I've always asked the postgraduate, what is the normal meniscal swing? A meniscal swing is that movement of water in the tube So the normal should be between 3 to 5. I'm giving you the answers. But if you find when there's no movement, you need to find out whether there's blockage in the tube. And sometimes if you have what we call any blockage or tissues, or when you have proteinous things within the tube, then sometimes it's blocked. You may need actually to milk the tube. And we can always demonstrate how you milk the tube so that you end up plucking out the tube. And in case the swing is too wide, what does it mean? If you have a lot of space in the pleural space, the swing is beyond even 5 or 8 or 10, and that is not very long, but it's just telling you that there's a lot of space that needs to be occupied by the lung. Or if the lung is eaten away, like you have CA lung, the swing may be wide. So with those, you can actually assess whether it is functional or not, or it is excess or within normal ranges. Thank you.
Okay, thank you very much. Thank you very much, Dr. Mary Ellen. I hope we have answered all the questions. As we transition into the next stage of our discussion, I want to ask Thomas to start posting the post test, and I want to invite him to do the closing remarks while we await any further questions from anyone on the chat.
I will just say, someone asked about a dislodged tube, and we were talking about not shoving it back in. You might want to just mention that if a tube becomes dislodged.
Okay, let me actually answer that one. When the tube is dislodged, we don't push it back. In most cases, actually, we may even actually need a new tube and then even a new site and close off that point where the tube has dislodged. When you just push back the tube, you're actually pushing in a lot of infection into the pleural space, which we know it is sterile. So those are some of the biggest causes of pneumothorax. So we don't recommend. If you have only that one, please let the patient afford and you get another. Or please donate and the patient gets another tube and you put in a new one. But don't push it just inside. Whereas if you are pushed too far, then you can adjust and drop it down a bit. And that is recommended, but not pushing into.
Is to be hoped that anyone.
Probably I can give my closing remarks. Thank you very much, ECHO, City Global, for the invitation. And we look upon these serial invitations so that we can teach the masses. And in that way, we also protecting the patients from getting unnecessary complications, but also passing on the right knowledge, skills, and good practices. So we look forward for another invitation to demonstrate to how to insert the chest tube and probably the different techniques and then the challenges that can be faced and then how you move. And we are willing to do that for our border and our country. Thank you.
Thank you very much, Dr. Kabweru. I think we have reached the end of our session today. Hopefully everyone has had a chance to fill out the post test. Thank you for the closing remarks, Dr. Kabweru. And thank you for all the time we have given to this session. Thank you, Sumaya, for the presentation. Thank you, Julius. Thank you so much, Andrew, for taking off your time for this educative experience. Thank you for all our participants for your questions. It has been very, very nice and educative having this discussion with all of you. Thank you for your attention. I want to ask Thomas to close our discussion for today. Thank you, everyone.
Okay, thank you, Jonathan, and thank you everyone who has attended the session. We are delighted to see you once again. Our next session is going to be in 2 weeks. We shall communicate those on the WhatsApp group, we communicate, and those that on email, we shall also send the emails. The video is going to be uploaded on the YouTube and the PowerPoints are going to be uploaded on the website. So when you go to the website, just put EMS Echo Uganda, you will see the page. Even on YouTube, you can put EMS Echo Uganda. We are going to do a small video to demonstrate how to insert a chest tube with a mannequin. We are going to record it and put it on the YouTube video, on the YouTube channel. So you will be able to access that. We shall work with the experts here, plus others, to ensure that that video goes there. Thank you so much. If you have any feedback, you can write on email. Otherwise, enjoy your weekend. Thank you.